To test for lateral epicondylitis, you may do Cozen's test or Mills test. For Cozen's test, stabilize the elbow of the affected extremity and have the patient turn his or her palm towards the ground so that the forearm will be pronated. Instruct the patient to make a fist and bring his or her knuckles upward and inward so that the wrist is in extension and radial deviation. For this test, the examiner will apply resistance upon the performance of the patient. The positive sign for this test will be pain on the lateral epicondyle of the humerus, indicating lateral epicondylitis. For Mills test, still stabilize the elbow of the affected extremity. But for this time, the examiner will passively pronate the forearm and fully flex the wrist with the fingers also flexed and the elbows extended. Positive sign for this test will be pain on the lateral epicondyle of the humerus, indicating lateral epicondylitis. To test for medial epicondylitis, you may do golfer's elbow test. For this test, the examiner will passively supinate the forearm and simultaneously extends the elbow and the wrist. Pain on the medial epicondyle of the humerus indicates medial epicondylitis.
To test biceps rupture, you may do hook test or biceps squeeze test. To conduct hook test, first, patient is either standing or sitting position. Then ask the patient to actively flex the elbow 90 degrees and have the palm face upwards to supinate the forearm. In case left elbow, you may use your right index finger and try to hook it under the tendon and bring it laterally on the antecubital fossa. In a normal tendon, you should be able to hook it approximately 1 cm or bring it forward laterally. You will know the distal biceps tendon is ruptured when you cannot hook your finger under the tendon, which indicates positive test. To test for cubital tunnel syndrome, you may do elbow flexion test or Mackinnon's crotch collapse test. To conduct elbow flexion test, have the patient's hands at the side, fully flex the elbow, and extend the wrist. Ask the patient to hold this position for 3 to 5 minutes. This test is positive when there is pain, numbness, tingling sensation in the ulnar nerve distribution at the elbow. To conduct Mackinnon's crotch collapse test, first the patient is in standing position with the elbow flexed 90 degrees. Then ask the patient to laterally rotate and abduct forearm against the resistance. And then relax. Then the examiner scratches along the course of the ulnar nerve at the elbow. Then ask the patient to repeat the movement against the resistance. This test is positive when the patient cannot repeat the movement after scratching along the ulnar nerve.
To test for ligamentous instability of the elbow, you may do ligamentous valgus instability test and ligamentous varus instability test. For valgus instability test, stabilize the patient's arm at the elbow with the other hand on the wrist. Apply valgus or abduction force on the distal forearm to test for the medial collateral ligament. Note for any laxity, decreased mobility, or altered pain on the site compared to the uninvolved elbow. For varus instability test, the hand placements are the same with the valgus instability test. For this test, the examiner applies adduction or varus force to test the lateral collateral ligament. Note for any laxity, decreased mobility, or altered pain on the site compared to the uninvolved tempo.
Now, I will be showing you two tests for circulation. One is what we call the digit blood flow test and the other is what we call the Allen's test. To test distal blood flow, the examiner compresses the nail bed and notes the time taken for the color to return to the nail. Normally, when the pressure is released, color should return to the nail bed within 3 seconds. If return takes longer, arterial insufficiency to the finger should be suspected. Comparison with the normal side gives some indication of the restricted blood flow. The next test for circulation is Allen's test. To do Allen's test, the examiner may use both hands, placing one thumb over each artery to compress the artery and placing the fingers on the posterior aspect of the arm for stability. The targeted arteries are the radial artery and the ulnar artery. The patient is then asked to open and close the hand several times as quickly as possible. The examiner notices the hands turning pale, and when the hands turns pale, tell the patient to stop. One artery is tested by releasing the pressure over that artery to see if the hand flushes. The other artery is then tested in a similar fashion. Both hands should be tested for comparison. This test determines the patency of the radial and ulnar arteries and determines which artery provides the major blood supply to the hand. The next test is the Finkelstein test. The Finkelstein test is used to determine the presence of a Decker vein or a Hoffmann disease, a paratendonitis of the thumb. To do the Finkelstein test, instruct the patient to make a fist with the thumb inside the fingers. The examiner stabilizes the forearm and deviates the wrist towards the ulnar side. A positive test is indicated by pain over the abductor pollicis longus and the extensor pollicis brevis tendons at the wrist and is indicative of a paratendonitis of these two tendons. Because the test can cause some discomfort in some other individuals, the examiner should compare the pain caused on the affected side to that of the normal side. Only reproduction of pain can make the test positive.
To check for swelling, you can either do the figure 8 measurement or the hand volume test. For the figure of 8 measurement, we'll be using a tape measure. So first, mark the starting point, which is the ulnar styloid process. Then go across the anterior wrist to the distal styloid process of the radius, and then go diagonally at the back of the hand, then over the 5th metacarpophalangeal joint, across the palm, then go at the back diagonally to the starting point. After measuring the affected side, compare the value with the normal side. For the hand volume test, if the examiner is concerned about the changes in hand size, a volumeter may be used. This device can be used to assess change in hand size resulting from localized swelling, generalized edema, or atrophy. Comparisons with the normal limb give the examiner an idea of the changes occurring in the affected hand. Care must be taken when doing the test to ensure accurate readings. There is often a 10 ml difference between right and left hands and between dominant and non-dominant hands. If swelling is the problem, differences of 30 to 50 ml can be noted. To test for fracture, you can either do the axial load test or the Watson's test. For the axial load test, the patient sits while the examiner stabilizes the patient's wrist with one hand. With the other hand, the examiner carefully grasps the patient's thumb and applies axial compression. Pain and/or crepitus
positive test for a fracture of the metacarpal or adjacent carpal bones or joint arthrosis. A similar test may be performed for the fingers. For the Watson test, the patient sits with the elbow resting on a table and forearm pronated. The examiner faces the patient. With one hand, the examiner takes the patient's wrist into full ulnar deviation and slight extension while holding the metacarpals. The examiner presses the thumb of the other hand against the distal pole of the scaphoid on the palmar side to prevent it from moving towards the palm, while the fingers provide a counter pressure on the dorsum of the forearm. With the first hand, the examiner radially deviates and slightly flexes the patient's hand while maintaining pressure on the scaphoid. This creates a subluxation stress if the scaphoid is unstable. If are unstable, the dorsal pole of the scaphoid subluxes or shifts over the dorsal rim of the radius, and the patient complains of pain, indicating a positive test.
Now, we're going to assess carpal tunnel syndrome, which has two tests, the carpal compression test and the Pollens test or wrist flexion test. For carpal compression test, the examiner holds the supinated wrist in both hands and applies direct, even pressure over the median nerve in carpal tunnel for up to 30 seconds. And for the positive sign, it will be the production of patient symptom. And also this carpal compression test, it is also the modification of reverse Pollens test. Pollens test or wrist flexion test, the examiner flexes the patient's wrist maximally and also to the other side and holds this position for 1 minute by pushing the patient's wrist together. And also the positive test indicated by tingling in thumb, index finger, and middle and lateral half of the ring finger. The indicative of carpal tunnel syndrome in the Pollens test is caused by the pressure on median nerve. For the last assessment of the hand, it will be the radiocarpal or midcarpal instability consisting of two tests, which is the catch-up clamp test and the shock test. For the catch-up clamp test, the patient has forearm inclination while radially and ulnarly deviating the wrist. Normally, during this movement, the proximal row of carpal rotates from flexion to extension, while distal row translates from anterior to posterior when going from radial deviation to ulnar deviation, and the positive test will be having a clunk. For the shock test or finger extension test, the examiner holds the patient's wrist flexed and asks the patient to actively extend fingers against resistance. Pain would indicate the positive test for radiocarpal and midcarpal instability.